Good morning, everybody. I want to welcome you all to the annual Gertrude Rogers Greenblatt Lecture. This lecture honors a child psychiatrist who embodies the admirable spirit of Dr. Greenblatt, recognizing a deeply humane commitment to children requiring psychiatric care, exceptional talent and skill in clinical work, and unusual sensitivity and concern for the needs and feelings of others, whether they be patients and families or students and colleagues. I can't imagine a better fit for this lectureship than Dr. Glowinski. Born and raised in France, Dr. Glowinski completed her medical training in the U.S., receiving her medical degree from Baylor College of Medicine, her psychiatric residency and fellowship from Johns Hopkins University, and a master's in psychiatric epidemiology from Washington University in St. Louis, where she's remained the majority of her career and is currently director of training for the Child and Adolescent Psychiatry Fellowship and associate director of the Child Division at WashU. Over that time, Dr. Glowinski has distinguished herself as a master educator, clinician, researcher, and humanitarian. While I could eat up all of her time impressing you with her 32-page CV detailing numerous accomplishments, awards, and publications, the thread that runs throughout the CV is a limitless compassion and dedication apparent in everything she does within her community and across the world. She touches deeply countless lives, from medical trainees to Rohingya refugees. She's similarly been committed to suicide prevention across populations, including within our own field, as you will hear today. When I asked her one thing that she would want us to know about her, she joked that she feels lucky that she's paid to simply be herself. But really, it's the world that is truly lucky for that. Please join me in welcoming Dr. Ann Glowinski, our 2019 Greenblatt lecturer, discussing breaking the silence, physician impairment, burnout, and suicide.
There you go. Well, it's a wonderful honor and pleasure to be here today with friends, including new friends. And because this is a lecture which is in honor of an educator, I have tried to integrate things about education in it more than otherwise. So I will start by telling you, I need this, that what you're going to hear is not just something about this important topic, but also because it is illustrative of the kind of denial and blind spots that physicians have, or people in our field and in our culture. I will tell you my story so that you can experience it as I tell it. So my disclosures, I'm not really good at making these slides, right? But what you see in the background is me holding a baby and lecturing at the same time, which is a theme for my life. So my disclosures are that I have funding relevant to education, including being the co-PI of an NIH grant to integrate research training into our fellowship and residency, and that I'm on a couple of advisory boards, including with the Klingenstein Third Generation Foundation. I'm sure you've had people here affiliated with this foundation, and I've been doing that for many years. It's been an important part of my well-being, actually. And that also I am an unpaid volunteer advisor for education and mental health for Friends in Village Development Bangladesh, which is a company, an NGO actually, that helps currently with education and mental health with Rohingya refugees. So here is where my story starts. I'm the mother of 3 children. And the reason this relates to burnout is, who has parented teenagers in this room? Okay, so fun, right? So I'm currently in year 13 of parenting teenagers. When I started, I probably would have had a D. Now I'm like a B- or something like that. But so when I started, I had son number 1, the guy with the pendant, who fought with me all the time. And then son number 2, the one who also is wearing a white shirt, who just ignored me completely. And then son number 3, the baby in the colorful shirt, was just surly and sort of like jabbing. So surly guy. So the story begins, but just with me. He's actually a very pleasant kid otherwise, So this is him with his brothers. He's got a completely normal range of facial expression. But with me, it ranges from slightly surly to extremely surly. So my story begins with, it doesn't exactly begin here, but let's begin it for you here. I'm in a car, and I'm driving surly teenager to school, and then after, I'm supposed to give grand rounds in my institution. This is about 2 years ago. And something completely uncharacteristic happens. Surly teenager goes, "Are you okay, Mom?" And what was going on is that usually I tried to drag interaction out of him, and he grunts back. And what was happening is I was dead silent, completely silent. And by the way, if you're a student, this is a good example of motivational interviewing. Don't try hard, just be chill, and then things come out. So he reaches out to me and he says, "Are you okay, Mom?" So I said, "Well, Sami, I'm about to talk in front of 200 people, and I'm going to tell them, one, that I have had depression for decades, and two, that I have been on an antidepressant for 2 decades. So I'm a little nervous." So big silence. And then he goes, "Mom, are you going to ease them into it?" Not like I did now, but. And so I'm so impressed by how thoughtful he is. And I say, "Why do you say that, sweetie? You mean like I should sort of build it up?" And he goes like, "Mom, half of them are going to be highly annoyed by your French accent. So you need to pace yourself." So why was I doing this? Why was I going in front of 200 people? Why am I doing this here today, right? I could have talked about any number of topics when I had the honor of being invited. Well, I'm doing this because things converged in my life and in the life of other individuals. I met with Dr. Borsch, I think, who has similar, different but similar threads of being in a place in her life where she's more interested and more knowledgeable about this topic than she was. So in my life, what was going on? So I told you about my personal life vaguely, so depression, medications. And then what was happening in my community is that in the summer of 2014, like in many communities in the United States, a black teenager called Michael Brown was killed. And when Michael Brown was killed, in a situation where, let's just put it this way, if he had been a different color, he probably wouldn't have been killed. This led to a situation like this in my backyard, in the backyard of Washington University. And one of the transformations in my community is that Washington University decided that it was going to take diversity in a different direction, the teaching about diversity in a different direction. Actually, I'm very happy to say that Washington University is launching an institute for the study of race, ethnicity, and equity, and that a child psychiatrist, Cynthia Rogers, who's a former trainee, mentee, friends, colleague, is actually going to be the head of it at the medical school. So there's going to be 4 heads, and the head of it at the medical school is a child psychiatrist, which is wonderful. But the first response 5 years ago, 4.5 years ago, was to interrogate the conscience of the institution who was struggling with itself and thinking, how do we teach diversity to our trainees? And they realized that some of their requirements just didn't quite match what was needed, because some of their requirements were, why don't you take a course in Viking ceramics, for example, and that will meet your diversity requirement. So they decided to revamp the freshman entry course in diversity. And so I get a call. And so one of my contacts at the undergrad campus, who's the head of gender, identity, sexuality department, says, Anne, I want you to teach a class on mental health as a minority status. And so I say, okay, you mean like if you're a black person, or if you're a homosexual person, or if you're all of these, you're a woman, you're homosexual, you're black, and you have a mental health problem. She said, no, I mean like if you have a mental health problem, that's the minority status. So I'm sort of somebody who gets high on intellectual stimulation. This was very intellectual stimulating because it was a complete no-brainer, and yet I had not thought about it before, not enough. So I said, okay. And then I thought about how do I teach that? And what do I need to read? So how to teach it was easy because actually my colleague is a graphics novel expert, so we decided that I would use a narrative by somebody very articulate who is a Seattle graphic novelist who narrates her journey with being diagnosed with bipolar disorder, realizing that she might need medicine, and then finally stopping to smoke pot to self-medicate at the very end of the book. So basically all these stages are narrated wonderfully, including the part about asking herself whether she's an artist who has talent because she's bipolar, and doing her own research to understand that. And because she's a graphic novelist, she uses images that are very compelling and easy for teaching. I'll show you one of them or two of them. And then I read about stigma. And I read about the history of efforts. So this is the graphic novel. I don't know who has read it in this room. It's really highly recommended. If you're a teacher trying to explain to a student what flight of ideas is, there's a perfect image actually in this. But so I read about this kind of research. And so there is a long history, this is in the American Journal of Public Health, there's a long history of using vignettes, they used to be called the star vignettes, which portray something like this. You know, here is somebody, this ethnicity, and they have these symptoms, and what do you think? And it queries the public about what their perceptions are. And what really this research is showing is very interesting. It's showing that what we've believed as doctors, or what the subtext has been, which is if we explain to our patients or to the public what a mental illness is, then we're going to destigmatize it. That education is essentially the number one vehicle for destigmatization. That showing a picture of a brain, for example, and saying this is where depression is, that's going to destigmatize. That's what NARSAD is about, right? That's what a lot of our science is about. Does it work to destigmatize? It does not. So what it shows is that, I mean, I'm not saying it does not, 100% does not, but it does not enough. And actually the proof, and I'm going to come back to that, is that we, people who know about mental disorders, do not feel the same way when we have mental disorders, do we? So we may know about them, but our behavior suggests that what you know and how you feel are two very different things. So coming back to this, what I learned is that stigma endures way beyond understanding, that in the last decades people have learned that maybe depression is a disease, but they're still scared of people with depression. A substantial amount of Americans are scared of living next to somebody who has a depression, even though this is a disorder that is as common as the common cold, right? And what I also learned is that there's a rich literature on stigma, and that stigma, if you try to quantify its burden, is almost equivalent to the burden of having an illness. So you have an illness, and then you have the stigma, and it's a double burden. And then if we add the intersectionality of other things, like I had mentioned, obviously it's even further amplified. So at the same time, what was going on in the country is that the ACGME, so for people who are students, this is the accreditation for graduate medical education. And there are review committees. It's a very big organization. It's based in Chicago. But what it does, it oversees the graduate medical education all over the country, just like AAMC oversees it for medical school, undergraduate medical education. So I've been on the RC, the review committee for psychiatry, and didn't see this coming. We were talking about burnout, we were talking about suicide, and suddenly the mandates changed. And the way that they changed, essentially, and I've highlighted some of this, is that what it said to all the training directors in all of the country, in every specialty, is you have to pay attention to the mental disorders of your trainees. You have to pay attention to the environment, the well-being, the mental health of your faculty too. And not only that, but you have to prioritize that. So to say that this was a sea of change, it's not even an understatement or an overstatement. It's the truth. Because I can tell you that as a training director, what we were supposed to tell trainees before was something like, oh, you need to take care of your teeth. Okay, make sure that your appointment is very early in the morning or very late so that it doesn't disrupt patient care. Oh, you need to see a therapist? Make sure that it doesn't disrupt anything. And basically what this is saying is, no, you guys cannot do that. What you have to do now is create an environment where you are modeling that self-care is important, that taking care of your own health is important, and also you need to let it happen. And furthermore, recognizing that mental health resources are few and far between in a lot of places, what it told institutions is, okay, you guys have to also make sure that there are services available for mental health. So this would be, in terms of the culture change that is asked of medicine, this would be like if you arrived in France and you told French people that they had to eat in 15 minutes on Sunday. Like a very big culture change. Or that they could only eat one kind of cheese. So because what is our culture? So let's talk about that a little bit. So our culture has an official heading of first do no harm, right? Primum non nocere. But we also have hidden curricula. We have things that are very powerful, that are not stated in the Hippocratic Oath, but that affect how we behave. So what do we know? Everything here is a fact. We know that there is an entire 1 or 2 medical school size group of doctors that die every year from suicide. We know that if you compare us to the general population, males are dying a little more by suicide, but it's especially the women that are dying by suicide more than females in the general population. And so when I read that, I thought, oh, maybe we're just horrible at taking care of ourselves. We don't take care of our cancers. We don't take care of our hearts. That's not true. We actually do a better job than the general population, in part because maybe we have access or whatever it is. Our knowledge about medicine translates in better outcomes for everything else, not for mental health. So how do we die if we commit suicide? We use overdoses. And one thing that is very important is that the suicide to suicide attempt ratio is very small in physicians. So to give you an idea, if you're like me, a child and adolescent psychiatrist, you're seeing patients where the suicide to suicide attempt ratio is about 1 in 100. There's a lot of suicide attempts to one suicide. If you're a geriatric psychiatrist, like maybe somebody in this room, you're seeing patients where the suicide to suicide attempt ratio is 1 in 4. So for physicians, we're dealing with that kind of suicide to suicide attempt ratio, a very serious suicide to suicide attempt ratio. Why is it elevated? So my first thought, because I've dwelled in sort of high pressure medical school systems like Hopkins and Baylor to some degree, and now WashU, is, oh, we're just more neurotic. You know, you hear that, right? You hear things like, oh, we're all type A, we're all this, we're all that. It's not true, folks. It's actually not true. It's maybe true at UCLA, it's maybe true at Hopkins, it's maybe true at WashU. It's not true for every doctor in the world. Basically, it looks like people who go into medical school are not at higher risk of depression and anxiety and suicide to start with than the general population. I'm going to repeat that. It's not that you have a self-selection of people at risk going into medical school, because that would be a convenient story. That was my first thought. I did behavior genetics. I thought, of course, it's basically a genetic vulnerability. Plus, it was a little autobiographical for me, so it made sense. It's not true for most doctors. So basically, what studies show is that you arrive with sort of an average risk, and then you get depressed and anxious and suicidal. And that medical students and residents have, during training, so after they enter, an increased risk, not before. Now, when you're an older person like me, although I don't feel old, but you start approximating general population level depression, anxiety, etc. But here is the story. This is a very important piece of my story. When I was reading about stigma, the reason that I decided to tell everybody that I had depression was the following. So I'm reading the chapters about stigma in the general population. And then I read the chapters on stigma in physicians. And if you, like me, have been on the consult service and dealt with attitudes of other physicians towards psychiatry, you know that most of us would be like, oh yeah, it's terrible, stigmatized. So, okay, I read that, I'm like, yeah, it's terrible. And then the chapter about psychiatrists and social workers and psychologists, guess what? We're the worst. We are the worst. So we're the worst about self-care. We're the worst at acknowledging when we have a problem. We're the worst at getting help. We're the worst at telling our bosses, our friends. And so for me, this was like tearing a blind spot that I had, because I had this rationalization that even though my values tend to be transparency and honesty, always thinking maybe this will stop working at some point, somebody's going to fire me because I'm honest and transparent, and it hasn't. But I wasn't honest and transparent about having depression. I would deconstruct what it was like to be a mother, what it was like to have hypertension, what it was like to be an immigrant. I would deconstruct everything, not what it was like to have depression, not what it was like to have an illness as a doctor. So I read that, and I realized that I am one of those people being described, especially because if you know me, I have a lot of friends. I'm a very fortunate person that way. I hadn't told a single friend, not a single friend, that I had that. My husband knew. We never really talked about it, but he knew. And then my kids knew. We didn't talk about it either. It was just in passing. So when I read that, I emailed my chair, Dr. Zoromsky. And he's the kind of guy who always answers you, except if you're asking for a raise, and he just doesn't. But if you send him an email, he answers right away. So I sent him an email, and I'm like, you know, Chuck, I'm reading this research. It says that psychiatrists don't talk about their mental health. They don't tell their bosses. So I'm telling you, I have depression. I've been on antidepressants for 2 decades. If I try to get off, I crash. And then oh, and by the way, the reason I told him that is because the research shows that there's this perverse hierarchy. So people talk about having depression and anxiety. But the second layer of stigmatization is the treatment, because it's not a victorious narrative. You can say, I have depression, and I exercised myself through it. I ate kale through it, and now I'm amazing. But the story where, yeah, I have depression and I'm eating kale and exercising, and by the way, I need my SNRI, that's not as attractive a story, apparently. So I told him the whole story. And he doesn't answer for 10 minutes. And during those 10 minutes, I go through a festival, an explosion of cognitive distortions. And the part of me that can observe things is like, what the hell is this? Because I was like, oh my God, when I did this, and he's thinking that, and he's blah, 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 and I'm going to get fired. And then he answers, and he says something along the lines of, you know, I have the utmost respect for you. we need to do this. If people don't do this, we'll never change. And you've always been a leader, and I will support you if that's what you want to do. And the discrepancy between that reality and my cognitive distortions was a gift, in the sense that it highlighted my shame, the burden I was wearing, and I put that in a different place. So I'm not telling you that I don't have it at all. We're human, right? But it's not driving my boat anymore. It's not. So why is the suicide rate elevated? So that's one big reason. We're horrible at getting support. We're horrible at doing things that we know our patients need to do to get better. We don't do that for ourselves necessarily. We have increased stressors compared to the general population. We're in the trenches, and I'll come back to that. There is a repetitive and never-ending nature of our job. And what I want to qualify, I think my job is wonderful. What I'm talking about is if you were to look at it in what is the most pessimistic view I can have of my job, very clearly you could say, yeah, so you keep working in systems where things go in different directions. This is what the hospital wants, this is what the community wants, this is what I want. Nothing is necessarily aligned and works together, so it's very stressful. And obviously I can also have a positive narrative that I get to work with wonderful colleagues and amazing students and be inspired every day, and that my patients essentially have taught me how to be a human being in a way that many other jobs wouldn't have. So it's been a tale of growth, but it hasn't been a tale of easy growth. So our culture, let's talk about our culture. What studies suggest is that the majority, this is a recent study, the majority of medical students literally feel, even now a little bit, that if faculty and peers know that they have mental health struggles, they would view them as incompetent if they have depression. And that asking for help means not being able to cope. This is changing, this is a moving target that's changing rapidly with these new mandates, but I would say that this is still pretty recent. And that there's a risk, if you tell somebody that you have depression, there's a risk you're going to be punished, you're going to be taken out of the game, you're not going to be allowed to graduate or work. So in other words, and this is the graphic illustration, like sort of this idea that your disease, people will not see who you are. You talk about having something, and then that overwhelms the view that people have of you. They no longer see the individual in front of them. They see something scary called depression, called bipolar, called something. So we know that there's a mind-body dichotomy, right? We understand that it's on our licensure questions for many states. There are people who have made fun of this, like, let me see. Do you guys see it? It's not moving beyond. Let me try the other direction. Wait. Okay, yay! Teamwork.
Listen, I know you're sick and all, but are you even trying to get better?
Hey, look at it this way. There's plenty of people out there that have it worse off than you do.
You need to stop focusing on all the bad things in life and just try to enjoy it. It's all in your head.
I don't think you need to be taking medication every day just to feel normal. Don't you think it's changing you?
Listen, you really just need to suck it up. Like, everybody goes through this, and you're just feeling sorry for yourself.
Why don't you just go to the doctor?
The insurance doesn't cover the flu.
Steven! Man, that's broken. You need to see a doctor.
Seriously, I'm fine. I can get better on my own.
This is where I'm probably never gonna be able to stop this. Wait. And boom. Okay, so now, how do I get back to this?
Shot suggestion on the S10
There
Plus
must be
guides me to the perfect moment.
Next to me, it's still going?
Scene
That's so
Optimizer
funny.
knows what's in my photo and makes it better. Intelligent
If
camera,
somebody is
pro
high-tech,
quality photos.
please come here because I think that, I think, thank you. Minimize the video.
Hi everyone. In this video I thought I'd introduce you to my various personalities. How this is going to work is several, but not all, are going to have a segment where they talk freely without a script. The only part that is scripted is this beginning part. Because what they will say is unscripted and uncut, it is very difficult for me to do because I feel like some of it can be quite...
Thank you. Sort of thinking about our culture, one of the things that is very clear is that we do teach coping skills for things that are obviously stressful. So if you think about some of our job being akin to having to run in a building to rescue things that are on fire, most of the culture, as advices that we've all received, gives tips like, you can't take it home. Don't let it get to you, which is essentially saying, park it, compartmentalizing. And it's a really good advice if you're a firefighter jumping in a burning building. You definitely don't want your firefighter to be thinking about his feelings in the middle of rescuing a young child in a building that's on fire. The problem is that this is a very acute coping skill, and it really doesn't work very well for the long term. Thank you so much. You guys are wonderful. So, yay. So that is what is obvious about burnout in our field, is that we have a lot of things that are happening in our lives that we have somehow trained ourselves to believe are completely manageable without even debriefing about them, without debriefing substantially about them. Obviously, in psychiatry, we have a debriefing culture. Supervision is part of what we do with residents, but it's not necessarily something that we model systematically, especially as attendings. So if you think about it, we have a lot of things that happen that are stressful. We have a culture that tells us that being strong means that you're like a miracle of human nature. Stress doesn't get to you. And then we have a culture where talking about weakness, it makes us cringe. It makes us scared. So that, a friend and I proposed, was at the heart of burnout. I'm not going to open a new window because of what just happened, but basically, my colleague Dara Harris and I wrote this blog entry for Kevin MD where we talked about that. We said, you know, people talk about the electric medical records and all that, and it may be catalytically important, but what is really important is that we are putting a lot of feelings in a big box and we're just leaving it there. And if you think further about it, this is not in the blog, but this can explain why doctors can be so boring at parties, right? Like it's sort of perseverating on a few themes and not capable necessarily of veering off a few topics. When we published this, I got an explosion of texts from medical students who essentially said things like, you know, Dr. Glowinski, I just saw my first patient die, and this is what happened. I gave CPR to my patient, and then that person died, and I had bonded with that patient because she was my patient for 2 weeks on internal medicine. And I looked at my resident, and my resident said to me, at least you learned how to do CPR. And that's the only thing that they said to me. And then another medical student texts me and says, you know, I was just in the emergency room and I was working in trauma, and we had a patient come in with a gunshot wound, and we tried to resuscitate that patient for 2 hours, and they died. And after they died, the resident turned to me and said, there's another trauma in the room next door. So I got all these stories, right? And do these stories sound familiar? You all have stories like that, right? So what we're teaching our young is what we learned, which is you're tough, you're strong, you don't dwell on it. And again, I'm not saying that the trauma point is the time to debrief the student, but it's how you say it. It's whether you say something like, honey, we're never going to talk about this, versus this is an important thing to talk about, not now, because there's a trauma in room 4, I'm sorry, but I know you're feeling something. So it's that, which in my opinion is very toxic. One further thing I will disclose is that I thought I was really in touch with my feelings. So, and you know, a lot of the burnout questionnaires have to do with how you feel and their self-report. So I thought I'm a psychologically minded, I'm in touch with my feeling. I probably do some of this compartmentalization, but I'm probably not that affected. And so I put a device that is actually made by a company called BioVotion, a Swiss company. It's sort of a proxy for measuring whether your sympathetic nervous system is firing up. And I was in clinic and I put this machine, and the Schmidts were coming. So the Schmidts are that family where all my trainees are like, the Schmidts are coming. And they're stressed, and I'm like, this is nothing, it's okay. I'm a resilient, strong person. It's fine, it doesn't even get to me. And that's how I felt. And what the machine showed is that the Schmidts were coming. And my body knew it. So I'm not just going to leave it on this note of, especially because you have so many wonderful people here, like Karen, like Brenda, I met also today, who are doing this amazing work about well-being. So I'm going to just tell you a little bit about what we've done in my program, and also talk a little bit of the transformation that self-disclosure role modeling has been for my division. So first of all, there is a toxic culture of psychiatric exceptionalism, right, where we don't talk about psychiatric disorders in the same way as we talk about other disorders. What happens when you're in a residency program is that, so if you have your resident that is out because of a dislocated shoulder for 2 days versus out for something that has to do with a psychiatric disorder that needs appointments, the communication is going to be very different, on average. Obviously, there's many variations depending on the program. And you can't ask your residents to self-disclose. But what I tell my residents, by modeling my self-disclosure, by the way, is look, what I've observed over the years is when you make something a secret, especially with people who are your friends, and you don't at all talk about it, sometimes there are weirder dynamics that happen. Like people get more frustrated about covering for you, or they get more distanced from you, and you're already experiencing something that is making you feel isolated. So we have conversations like that. The other thing is that I have thought a lot about professionalism because of the contradiction, in a sense, that happens when we don't treat psychiatry like it's everything else. So one concept of professionalism that I've found very helpful as a training director is this concept of public professionalism, how I behave in social media, how I behave here, how I behave if I go and testify in a state setting or a national setting. Interprofessionalism, how I'm behaving with Dr. McCracken or social workers in my clinic or my students or my patients. Intraprofessionalism, how I behave with myself. So I have come to believe that the expectation should be professionally, as a physician, that I recognize that how I take care of myself affects the space between me and other people. So intra becomes inter. And that basically if I don't take care of myself, including of my psychiatric issues, if I don't take care of myself, then I am impacting my patients, my trainees, including at a role modeling level, but also at a profound, direct level. And I'm not telling you that taking care of myself is always seamless, because taking care of yourself may be very complicated, and it may interface with other forms of professionalism. Sometimes it might be, I'm trying to take care of myself, and I'm not there yet. How do we compensate for that as a team? But the bottom line is that we need to have these conversations without exceptionalism, or we're always going to be stuck at trying to treat people's mental disorders while we model that mental disorders are something shameful. And that doesn't work very well for our patients. So going back to this question of what is well-being and mental health promotion, obviously it's way more than just the treatment of mental disorder. And I'm going to tell you that it's something we take very seriously in our program, and these are just examples of activities that are meant to be mental health promoting for the team. So first of all, I don't know if this, I'm going to not press any of this. Okay, so I'm just staying away from the buttons. But if we start at where it says addressing mental health in the medical community, this is an example of a panel that actually one of my trainees just did with me recently, where we both talked about having depression. This is an ice cream break where we moved a lecture outside. We have something called zoodactics. I'm going to show you a clip so that you understand that it's something very serious and very educational, where we learn about genetics. Sometimes we have meetings at the gym to work on presentations. Obviously, we have a million baby showers and things like that. We have a curriculum that I'm going to talk about, and there are penguins in this curriculum. And when we're at national meetings like ACAP, we try to do activities that are also mental health promoting. Like we've done improv, for example, with trained leaders. So this is an example of our zoodactics, and hopefully this is one thing where I'm not messing everything up.
So when and how like a dogs came to become split off from the wolf population, and they actually looked at like a region of the genome that's associated with like a Williams syndrome, which is a hypersociability type of a phenotype in humans, and they found that the canines had structural variants in the genome that's associated with like the Williams or syndrome, like a locus in humans, and that's why there's that hypersociability aspect. And so they did some experiments. There was like a task where they had to get into into a cube, like to get a sausage, and they did this in the presence of a human and in the absence of a human. And when there's a human present, they get very distracted. The canines do. They get very distracted by humans. And so they have like an intentional, like a bias towards humans, and they have a preference to go up to humans and spend more time with the humans. And then the wolves just really like dig into that cube to get like the hot dog in the middle of the cube, but the dogs get way more distracted. And then they did like.
So anyway, you get the idea that whenever there's a possibility of combining well-being and education, we try to do that. I have a leadership seminar that basically we've done for many years, which is in essence everything that I wish people helped young people with. It starts actually with something that we tried to do a little bit with the T32 trainees yesterday, which is, what's your story? With the idea that anchoring your experience and your choices in really what is driving you is a good way of weathering the many variations in faith that you have with the choices that you make, especially when you're young. We also talk about culture, so this is really important. This is from a book called Tribal Leadership, which I highly recommend, which essentially, instead of focusing on the behavior of individuals, focuses on the behavior of groups, with the idea that a gang mentality would be like level 1, life sucks, so everything goes. a mentality after that which impacts a lot of trainees is my life sucks and everybody else has a great life. And then right after that is what a lot of medical professionals are modeling in an academic center. I'm amazing. I have a lab, I have a statue, I have this title, and everybody else is inferior. So level 3 and 2 depend on each other, but it doesn't take you further. And then level 4 is we're great, we're a great team. Level 5 is aspirational, like Nelson Mandela's reconciliation and truth, sort of the idea that we take the world as it is and we try to find it wonderful for all of us. It's aspirational for human beings. The last thing I will say, which we'll also do in this leadership seminar, is that it's very important for older people to recognize that structurally there are reasons for which it is harder for younger people. There are reasons why the burnout and the depression and the suicide is higher in this group. And it has to do with, in a sense, the stages of development that you are when you're young. So this is a Japanese concept. I'm sure you've seen books about this. What I like about this is that it helps illustrate, first of all, you know, do you have a good ikigai or not? And also, it's not like an ikigai, like a guy that's iki, it's just ikigai. But also whether we can help our trainees approximate this even as some of those variables are not achievable when you're young. So if you think about it, what this says is that you're going to have reasons for being, for getting up in the morning at the intersection of what the world needs. So we're lucky because we generally work in fields where on most days we believe that the world needs our work, right? What you really love. A lot of us are lucky. Again, when we're at our best, we love being with patients, we love teaching, we love doing research. At our best, we love what we do. What you're good at. When you're a trainee, you're not good. That's really hard. So you're not good or you don't think you're good because the complexity of the skills that we're learning in science, in teaching, in clinical care, they're not the kind of skills that are like driving a car. They're things that take years to get good at. So basically, when you're a trainee, you're in this sort of antechamber of goodness where for many, many years, your ikigai is out of whack because you're not good yet, right? So helping trainees, being good at being a trainee, being good at learning, being good at the stages that they're at is really a critical function for faculty, I think, so that we don't continue saying, yeah, you're not good yet. One day you'll be there. Be patient. That doesn't work. You still don't want to get up in the morning if you don't feel that you're good at something. And then what you get paid for, you're not getting paid a lot when you're a trainee. Sometimes you're paying other people to be a trainee. So really understanding that developmentally and structurally, young people may have brains and youth and all sorts of advantages, but they're in a difficult place for truly enjoying the fruit of their labors because they're still working on it. And I'm going to stop there, thanking my team at home, thanking everybody here, and hoping that you got something out of this, other than the part where the slides were not aligning. So I have a lot of references. Do you have any questions? I think I have a microphone that might be working. Yeah, thank you.
Thank you so much. I just have a quick question. Earlier you alluded to diversity and sort of framing mental health problems as the sort of diversity variable. And you also alluded to sort of intersectionality, different identities coming together. Could you comment just from an intersectionality perspective on how your work interfaces with some of those other dimensions of diversity?
Yeah.
Differential impact on women versus men, gender fluid, ethnicity, etc.
So, so I would say that it's like pieces of a puzzle that are coming together, and a puzzle that may not fully come together. But in my own work, so we've done a lot of work with women advancement, for example, and we make sure that we talk about mental health within that setting. we have created programs for, so basically we've tried to put people who are informed about mental health where they can receive patients who have, for example, gender fluidity or who are trans or who are young gay patients struggling. So we've done things like that. For race and ethnicity, I think we're definitely, if this is a stairs, we're at the beginning of the stairs. But I think that I told you about my institution starting to really put money into this, and I told you that one of the heads of the new Institute for Race, Ethnicity, and Equity is a child psychiatrist. So basically, if we're looking at strategy, I think we're positioning a lot of people for good things to happen. But we have a lot of work to do. We have a lot of work to do, especially for intersectionality.
Do you think the epidemiology of the issue is different across those dimensions?
Yes. Yeah, the epidemiology of the issue, the epidemiology of services, the epidemiology of attitudes. Yes, for sure. Yes, sir.
Yeah, my name's Dr. Ryder. I'm a community physician for like the last almost 40 years here. And my question to you is talking about the destigmatization of therapy and explaining that to the house officers and people, docs in training, when they are stigmatized, when they have to reapply for staff privileges. It asks not if you have a depression, it asks if you've ever been treated for a depression.
Yep. So I fully agree with you, but I will also throw back at you that I think because the culture doesn't, so what I will say to you is that I am horrified by the state licensing question too, and I know that the APA is addressing that actually, and I've heard that there is supposed to be a change so that there's more homogeneity and that the questions are not ridiculous about have you ever had something. The questions, basically the standard should be, are you currently impaired? And not psych. But I also know, having owned my own denial and blind spot, that it may be important for every physician to also recognize that sometimes we hang on to excuses to continue hiding our symptoms under a rock. And I want us to own that better. Because I too was afraid of being decapitated by any number of things. And my fear is greater than reality. And I think that is the case for a lot of people. Not all of them, but a lot of people. Other questions? Yeah.
Sorry, thank you so much for today. You alluded to, sort of tongue-in-cheek, the role that really practical constraints have on physician wellness, like not being paid enough, having too many loans, working too many hours. To what extent is that a central part of the conversation, at least nationally? Even thinking about things like bias or not having faculty of color as mentors, the things that are a little less sexy or programmed into an afternoon.
So I would say that in terms of the money piece, I don't know. I mean, you guys are, people who are young are paid way more than we were, but I know that it's still not a lot. In terms of making sure that there is a priority given to lining up resources so that residents can have the therapy they need, can have the psychiatrists they need. This is a high priority for every institution in the country right now. Basically, they're struggling and scrambling to make that happen, and some are more advanced than others. And also, you as a training director really can no longer model things like, are you sure you, like, can you do your therapy on another day? You're supposed to prioritize this. I certainly have, and I'm sure people here have too. So that's part of the conversation. And then every place looks at things like maybe related to salary, like having childcare. So things, we understand that having lactation rooms for women and so that actually is being mandated. You can no longer be a program without having a nurse, a place where you can collect the milk. That's a huge thing. I remember when I was nursing, there was a sign somewhere near the bathroom with a cow with big tits, and it was called the moo room. So that would no longer be acceptable.
that's all the time we have for questions, but if anyone has additional questions, feel free to come up. Thanks, Dr. Glowinski.
Thank you.